Hi and welcome back to another video of Medic Notes. This video is on hiatus hernia. A hiatal hernia occurs when the top of your stomach pushes up through an opening in your diaphragm into your chest. Your diaphragm is the muscle barrier that separates your abdominal cavity from your chest cavity. A hernia is when any organ or tissue pushes through a weakness in the tissue barrier that normally contains it. Hernias are common, and hiatal hernias are among the most common types. These are the few types of hiatus hernia. Type 1. Sliding hiatus hernia. This is a cephalad displacement of the GOJ and proximal stomach through the diaphragmatic hiatus into the posterior mediastinum. The stomach is covered anteriorly by a sac of peritoneum but is bare posteriorly. Type 2 is a paraoesophageal hernia. This is when the GOJ remains in its normal position below the hiatus and the stomach herniates into the chest next to the esophagus. The stomach is completely covered in peritoneum. Initially only the fundus herniates, but eventually the entire stomach can enter the chest. Type 3 hiatus hernia. This has elements of both sliding and paraoesophageal hiatus hernias. And lastly, gastric volvulus. This may occur when a type 2 or 3 hiatus hernia enlarges so much that the entire stomach is herniated anterior to the esophagus upside down in the chest with the pylorus located at the diaphragm. Typically, the sliding hiatus hernia is discovered incidentally while investigating coexisting symptoms such as reflux, and although it rarely needs treatment, it is corrected by reflux surgery. On the other hand, paraoesophageal hiatus hernias commonly present with symptoms and surgical repair is indicated. This picture shows a normal stomach, a sliding hiatus hernia, and a paraesophageal hiatal hernia. For epidemiology, it can be demonstrated radiologically in 50% of population, and in 80% of GORD patients. 95% are sliding hernias. Other types are rare, and paraoesophageal hernia is more common in elderly people more than 70 years old. Symptoms include chronic acid reflux or GERD, heartburn, non-cardiac chest pain, indigestion, burping and regurgitation, difficulty swallowing, sore throat and hoarseness. For investigations, chest radiograph can be diagnostic. Lateral chest radiograph shows an air fluid level in the posterior mediastinum. Barium swallow confirms the diagnosis and may define the extent of a large intrathoracic hiatus hernia. Endoscopy rules out esophagitis and checks the position of the GOJ, which may be high in a shortened esophagus. For presentation and management of different types of hiatal hernias, sliding hiatus hernias are associated with, but not known to be the cause of GORD. There is no indication for surgical repair of an asymptomatic sliding esophageal hiatus hernia, but surgical anti-reflux procedures for persistent reflux resistant to medical treatment involve reducing any coexisting hiatus hernia. Whereas paraoesophageal hernias may present with postprandial breathlessness due to lung compression. Early satiety, dysphagia, history of reflux that has spontaneously improved over time, respiratory distress, bleeding gastric ulcer or gastritis, and rupture or gangrene of the intrathoracic stomach. Patients with a large paraoesophageal hiatus hernia may develop complications, so even asymptomatic paraoesophageal hiatus hernias should be repaired if the patient is fit. Surgery involves reduction of the hernia, excision of the sac, narrowing of the hiatus plus a fundoplication to prevent future reflux. The elective procedure is now usually done laparoscopically. A transthoracic approach is preferred in a strangulated or ruptured gastric volvulus. That's all for this video. Thank you.